So class, today we are going to talk about complications of sinusitis. In the last class, we talked about acute and chronic rhinosinusitis. So now you know that it is a very common condition. Oh, so I'm audible and visible, right? Right. So somebody, you can reply me in the chat box. So am I audible and visible to all of you? Okay, since nobody is replying, so I assume, okay, yes, okay, yes, okay, thank you for informing. Right. So, as you know that rhinosinusitis is a very common condition, but it should not be okay. But this, though it is common, it should be taken very seriously because there are chances of development of complications, just like otitis media, the discharge of ear. It has intracranial and extracranial complications, and the complications can become very severe, so that the disease needs to be treated. So in the same way, any infection or the sinusitis, it can result in several complications, and sometimes the complications, they can be quite fatal, right? So we need to diagnose those complications within enough time and treat them accordingly. So what do you mean by complications of sinusitis? Okay, adverse progression of infection beyond mucoperiosteal lining of paranasal sinus to involve bone and neighboring structures, right? Like orbit, intracranial cavity, and dentition. So sinusitis is the inflammation of the mucoperiosteal lining. So whenever it breaches that lining and it goes to involve bone and other structures, so it becomes a complicated part, right? Compromise in function of any body part due to sinusitis. So sinusitis, the complications may not be limited only to the local areas. You know? So you may think that from the paranasal sinus, it will go to the orbit, or it will go to the cavernous sinus, or it will go to the other parts like the frontal sinus and other parts in the skin, but not always. So any compromise in the function of the any part of the body due to sinusitis is also complications. Now, etiology. What causes complication? Not everybody, you know, though rhinosinusitis is very common, not everyone develops complications. So it is mostly due to weak immune response of the host, usually in young children and immunocompromised adults. Okay, inadequate or inefficient treatment. Infection by high virulence organism. Right? Abnormalities of mucociliary clearance, and persistence of allergy and blockage of sinus ostia, right? So these are the common causes, right? So this is all understandable, and there's nothing to explain here, right? So this is important, right? The roots of infection. Okay, the disease should be it should be limited to the mucoperiosteal lining of the nose and the paranasal sinuses. But why does it breach, or how does it breach? How does it go to the other parts? So in the nose and paranasal sinus, there are thin bones which separate the orbit from the nasal cavity, and that bone is lamina papyracea. Just medial to the orbit, there is thin bone, lamina papyracea. Similarly, there are so many natural suture lines in the human body. So through that suture lines, because suture lines are something like some defect, natural defect. And so from that defect, the infection or the organisms may pass to other structures. Similarly, there are some natural canals like infraorbital canal, right? From that, so it forms as a path for the microorganisms to travel to another part. Similarly, by retrograde thrombophlebitis, by diploic vein of Brachet, and closely related roots of upper second premolar and first molar. So this is something like how does the infection travel? How does the complications of the acute otitis media or chronic otitis media they develop into extracranial and intracranial complications है त्यसमा पनि हैन यो सुचर लाइन नै हुन्छ थ्रोम्बोफ्लेबाइटिस है by local erosion है so the mechanism is mostly similar. Now what are the common pathogens in the complicated cases? The Staph aureus, Enterococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, anorogs like Bacteroides, Aspergillus, and Rhizopus. So, if any question is asked, so the order should be same. So, classification, okay. So, there are acute complications and chronic complications, right? And again, the acute complications can be either local or distant, right? The second definition of or the part of the definition of complication was so compromise in the function of the any body part anywhere, right? So that is distant complications. So local complications are orbital. So this orbit lies in close proximity of the nose and paranasal sinus, intracranial, obvious, and bony complications and dental complications. All of them are in close proximity, and toxic shock syndrome. So these are the acute complications. And chronic complications, mucocoele, pyocoele. So it is assumed that it may be due to the complications of rhinosinusitis, right? But the patient may not have rhinosinusitis, but they still can have mucocoele, right? So that is why the query marks. Similarly, associated diseases like otitis media, etiolotonsillitis, bronchiectasis, atrophic rhinitis, and nasal polyps. Okay. Otitis media due to extracurricular dysfunction, and similarly etiolotonsillitis, right? Because this lies in close proximity, and this other condition of the nose. Now, so first we'll talk about, okay, look here. In this classification, okay, orbital complications, okay, and here again we are going to talk in detail about orbital complications. So this is important because eyes, they deal with the vision, and serious complications can occur if this disease is not treated properly or diagnosed properly. So again, the orbital complications are a varied type, like pre-septal cellulitis, orbital cellulitis without abscess, orbital cellulitis with extra-periosteal abscess, orbital cellulitis with intra-periosteal abscess, cavernous sinus thrombosis, and orbital apex syndrome. Okay, cavernous sinus thrombosis regarded as intracranial complication, right? So these are the four terms or four phrases that you need to know. I know pre-septal cellulitis. So what are the? So sometimes in the Viva examination, you may be asked this question: what are the orbital complications of rhinosinusitis? नवराज हजुर सुन म अहिले क्लासमा छु म कल गर्छु तिमीलाई 10 बजे सुन म कल गर्छु तिमीलाई म क्लास लिँदैछु कि अहिले मिसको है कल गरिहाल्छु म तिमीलाई So pre-septal cellulitis, orbital cellulitis without abscess. Okay, cellulitis means just inflammation of the soft tissue, and orbital cellulitis, right, with extra-periosteal abscess and intra-periosteal abscess. So these four phrases you need to know, right? And as you already know, intracranial complications can be meningitis, extra-dural abscess, sub-dural abscess, intracerebral abscess, cavernous sinus thrombosis, sagittal sinus thrombosis, right? So we have already talked about intracranial complications in the ears chapter, right? So we are not going to go into detail, and we will only talk about how the intracranial complications will develop in cases of nose. And about the intracranial complications, you are also going to learn about it more in the neurosurgery classes, right? And other local complications like the bony complications can be osteitis or osteomyelitis, and dental complications can be dental abscess and oro-antral fistula. So this is one of the most important complications, right? Orbital complications. So commonest complication of sinusitis. Young people are at high risk. So in more than 85%, the affected people, they are younger than 20 years of age. But you also need to know that because of antibiotic, very good antibiotics and diagnostic modalities, this disease, the orbital complications are not usually seen. Ethmoid sinus most commonly implicated. Okay, so because the ethmoidal sinus is separated by laminae preparation from the orbit, and the ethmoid sinus lies in the close proximity of the eye, and then the frontal sinus, sphenoid sinus, and the maxillary sinuses. Now, right? So, it's my error. All of you look at this these pictures, right? Here, and kind of infection, right? Infection or कसरी extend भइरहेछ हैन, how is it extending, right? And what are the areas, right? And here the pre-septal cellulitis and diffuse cellulitis. Okay, all of the soft tissue, they are inflamed, right? But there is no abscess. And look here, there is the formation of abscess, right? And here also abscess. Okay, this is extra-periosteal abscess, and here the cavernous sinus thrombosis, right? The infections, they directly involve the cavernous sinus, right? Pre-septal cellulitis. So this is the area that is commonly involved, right? These are the eyelids. So infection external to periorbital septum. Edema of eyelid, upper lid, it is usually implicated in frontal sinusitis, lower lid mostly in maxillary sinusitis, and both lead in ethmoidal sinusitis. There is no erythema or tenderness, proptosis, extra-dural movement restriction, or vision change. Pre-septal cellulitis. Okay. Look here, there is some swelling, and here you can look that there is the skin fold. Right? What the skin fold is, it has been lost here. Right? So that is why whenever you examine any case of nose, the first step is always inspection, right? And in case of nose, in the examination of nose, I know because now you don't come for the clinical posting. So in the examination of nose, so the first thing that we need to look are also the orbits. Now this is how it appears in CT scan. Right? A case of pre-septal abscess. Right? Okay, pre-septal abscess here. And this is orbital cellulitis. So diffuse cellulitis with no abscess, right? In cellulitis, there may not be a formed abscess. It can only be inflammation. So infection inside periorbital septum, diffuse periorbital edema, mild proptosis is present, minimal or no restriction of extraocular movement, and no change in vision. So before this, we talked about pre-septal cellulitis, and now orbital cellulitis. Okay. So look here. Okay, here these are the orbits, and this is the nasal cavity showing the ethmoid air cells. Right? This is the ethmoidal air cells, and it is normal here. And look here, these are now there is inflammation of the sinus mucosa, and probably from here the infection it got transmitted up to here, and there is orbital cellulitis. Now extra-periosteal orbital abscess. So if the cellulitis progresses, it may form abscess. So localized extra-periosteal pus collection, mild proptosis is present, mild restriction of extraocular movement, mild vision loss, color vision is affected first. When red is seen as brown and blue is seen as black. Now here, this is a CT scan image, and you can see there is the collection of abscess. Now intra-periosteal orbital abscess. Okay, this mild chemosis, proptosis is there, severe, it can be severe, asymmetric, and quadratic, concurrent, complete, and there can be ophthalmoplegia and severe vision loss. Look here. So this is intra-periosteal abscess. So the further topics that we are taken in orbital complication, the severity of the disease is increasing. And all of these, it begins with pre-septal abscess and then cellulitis. And if they are not treated on time, and then further the condition deteriorates and it forms orbital abscess, pre-septal abscess, right? Exothalmos plus eyeball displacement, because there is something inside the fluid or pus inside that is pushing it outwards. Now, cavernous sinus thrombosis. We have also talked about cavernous sinus thrombosis in last classes. So it is a very dreadful condition because the mortality rate is very high. So let me tell you something about this. There is rapid onset and there is hectic fever, bilateral orbital pain and severe chemosis, bilateral absent pupillar reflex, bilateral symmetrical axial proptosis, sequential ophthalmoplegia, 6th nerve, 3rd nerve and 4th nerve, papilledema of and loss of vision, and painful paresthesia of the first trigeminal nerve and the second trigeminal nerve. This is how chemosis looks like, right? Bilateral chemosis and proptosis. So all of these result from untimely diagnosis of the rhinosinusitis. So when the when rhinosinusitis is left and not treated, the disease progresses to form complications. And when there are complications, then there are two things that you need to treat. One is the disease itself, and the next is the complication. But the complications need to be dealt fast, right? So the CT scan, this is sphenoid sinus, right? And here, this is the area of the cavernous sinus. Now, the cavernous sinus thrombosis and orbital abscess, they need to be differentiated. So, cavernous sinus thrombosis is bilateral, and but orbital abscess is unilateral. Cavernous sinus thrombosis is rapidly progressive. So, the results can be, the patient can rapidly deteriorate and the patient can even expire. So, this is slowly progressive. There is hectic fever, like picket fence fever and low-grade fever. There is severe chemosis, mild chemosis, right? And there is the paresthesia of nerves, trigeminal nerves, but no paresthesia here. Sequential ophthalmoplegia, here is concurrent pan ophthalmoplegia, and symmetric axial proptosis, asymmetric quadratic proptosis. Right? So these complications of sinusitis, right? This is also important for you, but this is a more important topic for especially the PG students, right? Because in your practice as MBBS students, maybe you not get any case of a complication of sinusitis, because this case is the complications are rare because there are plenty of ENT surgeons these days, and the treatment is and they often get enough treatment. So orbital apex syndrome, frontal headache plus deep orbital pain, optic nerve involvement causing vision loss, paralysis of abscess nerve, paralysis of oculomotor nerve, paralysis of trochlear nerve, and painful paresthesia of trigeminal nerve first and second. Evaluation of orbital complications. Okay, whenever a case, there is a case and you suspect that it may be a complicated form. So how do you approach the patient? Approaching the patient is quite important. Eye examination. Okay. So, like as ENT surgeons, we do not know how to do proper eye examination. So better get the help of ophthalmologist. Then look for the edema of eyelids, displacement of the eyeball, ocular movement, visual acuity, and fundoscopy for papilledema. And whenever there is even little suspicion, or so you always go for CT scan of PNS, right? Because CT scan will take all the small minute details, and so if there is any disease or not. Medical treatment. So when the complications they are in the beginning stage, The medical therapy can be done whenever there is only pre-septal cellulitis or orbital cellulitis, right? So this can be treated by aggressive medical treatment. So you need to give broad spectrum, high dose IV antibiotics, and analgesic, and nasal decongestant, mucolytics, and nasal saline irrigation. So complication and the basic pathology disease, this should be treated together. Now, surgical treatment. For sinusitis, okay, there are these words. Just know the names. You don't have to go in detail. Right? Frontal trephination, external frontal ethmoidectomy, Lynch-Howarth incision, and function endoscopic sinus surgery. Right? For orbital complications, sub-periosteal abscess drainage and orbital decompression. So for sinusitis, there used to be so many surgeries that are important from historical point of view. But these days, we have this functional endoscopic sinus surgery that has taken place for most of the other surgeries. Okay, Lynch-Howarth incision. Okay, here the eyelids, they are closed. This is called tarsorrhaphy, and here the incision is made here. Right, the eyelids are closed by this suture. Now, frontal sinus trephination. Okay, and whenever there is sub-periosteal abscess drainage, so it is drained like this, and the middle canthus is open, and the tissue they are retracted, and pus it is taken out. So you do this only after doing CT scan. You need to see the volume of the pus collected there, right? And do not operate only after clinical confirmation. There must be a CT done, and it will also show you the different structures around the orbit, and it will help you to guide through the surgery. Now, there is something called orbital decompression. So what are the indications? So no improvement in orbital symptoms in 24 to 48 hours of treatment. And if the CT scan shows the evidence of orbital abscess, and if the visual acuity is 20/60 or worse. So what are the results of orbital complications? So pre-septal cellulitis, orbital cellulitis, and other abscesses. So what happens? So exposure keratitis, because the lid they are retracted, uveitis, pruritus, ophthalmoplegia, glaucoma, and they can even be permanent vision loss. Now, we have also talked about intracranial complications elsewhere, so we are going to go very fast with these intracranial complications, right? Second complex complication of sinusitis, most common in adolescents and young adults, diploid immune system at peak vascularity, and frontal sinus most commonly implicated, then ethmoid sinuses, sphenoid sinuses, and maxillary sinuses. Commonest route of spread is retrograde thrombophlebitis via diploid vein of Brissett. Now you might have seen this diagram even earlier. Okay, so this is the brain parenchyma. So brain abscess is here, and here these are the meninges. Right, the skin is here, periosteum is here, and the frontal bone. Right, and this is how the subdural abscess is formed. Right, and here, okay, the extra-dural abscess. I know between the skull and the dura mater, and between the arachnoid mater and the dura mater, you get subdural abscess. And if the meninges, the layers of the brain, they are involved, then you get meningitis. And if anything in the brain parenchyma, you get brain abscess. So another diagram showing the same thing, right? In extra-dural abscess or epidural abscess. So the skull is here, and the dura mater is here, and here you get the abscess here, and the dura is here, and the infant mater is here, and you get it here, and the brain abscess right in the brain parenchyma. So clinical features, right? Fever, deep-seated headache, nausea and projectile vomiting, neck stiffness, seizures, altered sensorium and mood changes, and late clinical features of bradycardia, hypotension, and stupor. So CT scan is almost always implicated, right? In any case of nose, because it is a very large area, it covers a very large area, and there are so many areas that you cannot see. So you always suggest nose, CT scan of nose and paranasal sinuses. So abscess in the frontal lobe and also extra-dural abscess. So here you can see the frontal lobe abscess in MRI. So investigation and medical treatment. So whenever we suspect a case of intracranial complication, we get the help of neurosurgery. Okay, so there are many diseases which requires multidisciplinary management, and whenever you are in doubt or whenever you think that some other structure is involved, so do not hesitate to get help. So you always need to think for the betterment of the patient, how to cure the patient and send him back to his home healthy and happy, right? So don't think that like if you ask the consultation of some other specialty, then they'll doubt your expertise or anything like that, right? So CT scan of PNS and brain is done with contrast. MRI can also be done, right? So if there is something in the brain, right, go for MRI. And if you suspect, so CT scan is also very helpful, and it can solve most of the conditions. And high-dose IV broad-spectrum antibiotics, ceftriaxone and metronidazole is given for prolonged time, 4 to 6 weeks. And in like the role of steroids is controversial. Surgical treatment. So whenever there is sinusitis, so this is the same from the previous slide, right? So whenever there is sinusitis, okay, these days we go for functional endoscopic sinus surgery. So just like like we had one case here which developed brain abscess, and it was a case of chronic otitis media with cholestoma. So that patient stayed for a very long time in the hospital here, and he developed so many complications. So his the abscess was drained as well as the disease in the temporal bone. So MRM was also done, so that the source of the infection needs to be removed. So whenever there is a brain abscess, you don't only treat the brain abscess, right? So if it has developed due to sinusitis, then you need to treat it. So for intracranial complications, which are done by neurosurgeon, right? So borehole drainage is done for small abscess, and craniotomy for large brain abscess, right? Sequelae. So because the brain is involved, there are chances for seizure, hemiparesis, hemiplegia, and so intracranial complications are fatal. Right? So death can occur in 15 to 43% of the patient, right? So here I need to tell you one thing, right? Like hemiparesis in 2% to 17%. So why only 2% or why this range? Right? Because it depends on the research or the studies that are carried out. Right? There are some research, like if one research is carried out in Germany and they found that only 2% of the 1,000 or 2,000 patients in their hospital over 10 years they develop a hemiparesis, then in their conclusion or in their report result they write 2%. But if someone has done this report in USA or maybe Japan and they found that okay, it can result in up to 70% of the patient. Okay. So that is why all these complications or everything like this, it is given in a range, right? Because all of the resources that were carried out or the studies that were carried out, they were real and they were true. So it doesn't mean that it will only have 2% or it can have as high as 17%. So whatever the data that we're giving you or whatever the data that you are reading in your books, they are all evidence-based. It is not like that. I know. Just in my practice, I saw so for example, in my practice of 20 years, maybe I have seen 10 cases like this. So the ranges or the rate is like this. So that is not evidence-based, right? So that can be also regarded as evidence, but the level of evidence is very poor. So mucocoele of paranasal sinuses, right? So sometimes these things can be asked in exams, right? But it's not very common. But you need to know, right? Because this case mucosis mimics many other conditions. So what is it? Right? Epithelium-lined mucus-filled sac completely filling paranasal sinus and capable of expansion. So incidence. So mostly frontal sinus 65%, ethmoid sinus 25%, maxillary 10%, and sphenoid it is rare. So etiology, chronic obstruction of sinus, ostium with retention of normal sinus mucus with sinus cavity. Mucus retention develops from obstruction of ducts of serine mission exam within sinus mucosa. Clinical features: cystic non-tender swelling above inner canthus with exit crackling sensation on palpation. Diplopia and restricted eyeball movement, frontal headache, and retroorbital pain. Okay? So here this term is important. Axial crackling sensation on palpation. Right? So this is not very important for theory exam, but in practical exams maybe you could be asked this thing. And sometimes in the OSCE, mucoceles is given. So look here. So axial crackling. This is an important phrase in the diagnosis. Right? So the swellings, they are like this. So what are the differential diagnoses? Acute and chronic sinusitis, retention cyst, dermoid cyst, cholesterol granuloma, parenasal sinus tumors, and intracranial polyp. Investigations: CT, X-ray PNS, expanded frontal sinus, loss of scalloped margins, translucency, depression, or erosion of supraorbital. So you need to know this term, right? Scalloping, right? So normally the frontal sinus, they are scalloped, right? They are not a straight margin, right? They are just going like this, right? So in case of mucoceles, that is lost, right? CT scan, homogeneous smooth walled mass expanding within sinus with thinning of bone. So ring enhancement on contrast. So it is seen in piacile. So mucocele and piacile, they are very similar, but piacile, it has the pus along with mucin. So look here, the frontal mucocele. Right? This is how it appears here. Frontal ethmoid mucocele. You can see it here. Now here, frontal ethmoid mucocele. You can see it here. Now, because the mucocele, it has enlarging sides, so it is also causing proptosis. So if this is a normal eye, and if a straight line is drawn here, and see, this is protruding outside. Okay, so in maxilla, it is not very common, but sometimes it can occur, right? Look here, maxillary mucocele. Ethmoid plus sphenoid mucocele. So both in ethmoid and the sphenoid. Now sphenoid mucocele, right? So I'm skipping very fast because I know this is only relatively important for you. So what is the treatment? Right? Antibiotics and nasal decongestant, external frontal ethmoidectomy by Lynch-Howarth approach, endoscopic frontal ethmoidectomy, and endoscopic decompression by marsupialization and osteoplastic flap repair. Right? So this may sound a little difficult for you, but don't worry. Right? So antibiotics only because to treat the underlying inflammatory pathology, but the treatment is always surgical. So look here, this is septum, this is the metatarminate, and the mucocele, it lies here like this. What's floppy tumor, right? So this is also important for you. So it is frontal sinus osteomyelitis, fluctuant swelling over forehead anteriorly, may spread posteriorly to form subdural abscess, right? Treatment is 6 weeks of antibiotics, drainage of pus and debridement of bone, obliteration of frontal sinus by osteoplastic flap technique. Right? Just know the name, right? What's floppy tumor. We'll also learn about it in surgery class later on. Okay. So extra-dural abscess is here, and also the post-floppy tumor and the erosion of the bone. Oro-antral fistula. Okay, communication between oral cavity and the maxillary antral forms the oro-antral, oral cavity and the maxillary antral. Okay, so whenever the fistula is here, and because we take the food and so many things, so the debris or the food particles will enter through here. So it should be closed either by it can be closed by either buccal mucosal advancement flap. So we have talked about this advancement flap in the repair of the septal perforation as well. Similarly, palatal flap and buccal fat flap, right? So look, because of the complications that are developed in the nose and the ear, okay, the surrounding structures and also the distance complication. So always it is very important whenever you are given you find a case of nose, you need to examine the oral cavity and the ipsilateral ear and all other parts, I know, because they are quite related, and that is why ENT, it has been grouped together. right? Okay, it is saying that less than 1 minute, so I'm going to stop here, and okay, so and you'll have to rejoin while keep on joining. So we'll also go on with the classes slides, right? So Oro-antral fistula, you know. So I was telling that, so whenever you are examining, okay, whenever you get a patient either of ear or nose only or throat only, so using your diagnostic skill, so you also need to look for other adjoining structures, right? So in case of ear, you may need to examine the throat as well, because otitis media with effusion, it may have a pathology in the nasopharynx. There may be a mass there that may be causing tubular occlusion, and hence otitis media with effusion, right? Similarly, you can have a patient, okay, and as you just saw here, okay, there can be swelling on the forehead, but the main pathology, it lies in the major sinuses, right? So that is why you need to do a complete examination. Okay, this is how you look for the fistula. And here, so maxillary sinusitis there, and there is also the fistula. Toxic shock syndrome. Okay, you have heard this term so many times and in so many subjects. So it is rare, potentially fatal complications, septicemia due to Staphylococcus aureus or Streptococcus infection. So there is fever, hypotension, external rashes with desquamation, multi-system failure, and the treatment is by IV ceftriaxone 1 gram 8 hourly and drainage of sinus pus. Right? So that is all. Right? So this may be overwhelming for you, because you have learned about so many diseases and there are so many complications like mucocoele or periosteal and orbital, and those terms may be confusing, like pre-septal cellulitis, orbital cellulitis, and sub-periosteal abscess, extra-periosteal abscess. Right? So you need to review it again, read it for multiple times. So the importance is, in the OSCE examination, definitely you will be asked one question or more question from this topic. And as clinicians, you should be well aware and look out for the causes, the basic pathology of the complication. Suppose there is chemosis or the proptosis, and you only treat on the orbit, then it is never going to treat the patient. Suppose you are in a periphery, and you think that the pathology is only limited to the orbit, and you give antibiotics and do like that, but you don't have facility for CT scan or anything like that, then it may not be possible for you to diagnose the disease, right? So what you need to know is that these complications, either intracranial or the orbital, or even the systemic complication like toxic shock syndrome, they may have fatal consequences, and so that is why they need to be treated aggressively and promptly, right? Oh, listen, so okay, students, do you have any questions regarding this, regarding complications? If you have anything, then you may need to you can ask me, but make sure that after you finish the class and after your class, all the classes for today are finished, so you turn the chapter of the book and go through the pages in your book, right? Okay then, so nobody has